السلام عليكم. كل عام وانتم بخير، ومعكم الدكتور عبد الله. رحب بكم في كورس القسم بالنيابة عن جميع أعضاء الكورس. أول محاضرة من محاضرات أبريل تعتبر محاضرة تحضيرية لما قبل الكورس الكورس MCQ اللي بيبدأ في ماي إن شاء الله. This is preparatory series of lectures prepare ourselves for the part 1 exam, how to pass part 1. We have an elite group of speakers. One of them is Dr. Mohammed Al Kathlan, infectious disease consultant. He will talk about Antibiotics Simplified. Dr. Mohammed, mic for you.
الله يعطيك العافية. Thank you for Dr. Abdullah and for Dr. Mohammed and for all the people who's handling this course. It is a great course and I hope success for everybody, inshallah. It will be simple today, and the talk will be about the core of infectious disease, which is usually and mainly coming from bacterial disease. Other branch of infectious disease also coming in the exam, which include viral, parasite, and mycobacteria, and you can also go with the immunocompromised conditions like HIV and so on, and transplant. But the main core usually in infectious disease, especially in the exams, is related to bacterial disease. دكتور عبد الله الصوت واضح؟
واضح، تفضل.
تمام. Usually when we say antimicrobial or antibiotics, by basically everybody should know about bacteria itself and how to find bacteria. So we will go through some introduction, and it will be, inshallah, it will be light, but it's very important to know about it. So the first one, what's in front of you now, these pictures represent actually the sampling and how you can find your target, which is the bacteria. So these basics, you should know them. So when you read any question, you can understand what's going on. So here you can see the needles. It's for blood sampling, and here the swab, and here you can see for urine, and you can apply it for sputum and for CSF. These things called samples. So where you can get your sample from this area. Second thing, clear my drawing. Second thing is the media. So you took the sample from the sputum, from CSF, from blood, then you have to put them in the media, and this is the media. Here you can see the blood culture bottles and or the swab, and in this, I think nobody can see them nowadays. This for anaerobic collection sample. So you should collect your anaerobic sample in a media without oxygen, and this is the best media for anaerobic. Third thing, after collecting the sample, this is one of the way where you put your sample in the lab, which called incubator. نقول الحضانات هذولي. For blood, usually they are putting them in a directly in the incubator and wait until you get a growth. After growth, then you have to make another culture. Other sample, which directly we will put them in the plates. Blood agar, maconchi, and so on, many plates. So we will put, for example, the drop of urine, and we will spread it in this media. And then we will put them in incubator, like in the blood. The difference in the blood, we will put the bottle directly in incubator, but here we will have to embedded them in the plate and put them in incubator. And we will wait until there is a growth. After the growth, the microbiologist, he will make some of reaction and processing to find out what's the type of bacteria that we want to kill. For example, here, maybe this common place for MCQ, which is catalase and coagulase. So when he knows he's dealing with a gram-positive, he will do catalase or coagulase. So in the end, he will tell us this is streptococcus or staphylococcus. And for gram-negative, they will do other tests. Or they can see it directly in agar, like hemolysis, and he will tell us what's the organism. Then, after that, it's like that. He has diagram. By the way, this is only simple description. Otherwise, they have more automated, more sophisticated process. So he will have gram-positive in front of him in the lab, and it's cocci, and catalase is positive, so it's staphylococcus, and he will make coagulase, and if positive, so it will show up for us, it's Staphylococcus aureus, and he will do the sensitivity, and we will end up in the care, in the health system that we are using, which is one sensitive, which is one resistant. And the same for gram-negative bacteria. If you want to find some area for MCQ, usually this Coccobacilli area, you can capture, and you should also add Acinetobacter baumannii, which is Coccobacilli and Procella. They are the area where either MCQ or in the clinical exam also. So they are similar. Next. Here, what we should know at the level of internal medicine, if you will know more, it will be okay. So we have in the right side here, this is right side, gram-positive, and here we have gram-negative. This is the most important bacteria we are dealing with, and it's coming with. I will leave it for you, but let's go for the most important out of these. Here. We have Streptococcus pneumonia, which is common, usually where CNS and pneumonia. So Streptococcus pneumonia. And Staphylococcus aureus, it's important also because it's an area for questioning infective endocarditis and soft tissue infection. And also for hardware, implants, prosthesis. Enterococcus faecalis, usually it will come as a confusion with contaminant and GI colonizer, which can come in also line infection as well as MRSA and Staphylococcus aureus. Listeria important for CNS. Actually, if you want to add additional agent that we will discuss later. And these black, they are anaerobic. And those three, they like it, the examiners as MCQ, which is atypical organism. Usually, mostly they are coming in the lung, but don't forget chlamydia and mycoplasma, they can come as STD also. And C. diff, which is always we are omitting in the exam, and it's caused by antibiotic usually. And for spice, this one, if when you see them, you should know that they are may fake their presentation and the culture. They will tell you we are sensitive for this antibiotic, but they will become resistant after a few days from using these sensitive antibiotics by inducible enzyme resistance. So it will show you in the culture sensitive for ceftriaxone, but when you give ceftriaxone to the patient, they will show up, they're resistant after a few days. So we are dealing with them like ESPL. And Pseudomonas aeruginosa, it's usually linked with MRSA because they have special antibiotics. So you should know them. And these, the forgotten organism, everybody forget them, don't look at them, but they are coming in ICU. And not every antibiotic covering them. They are covered by few antibiotics, mainly Bacterium, Meropenem, ceftazidime. For example, this one may be sensitive for ceftazidime, but resistant for ceftriaxone and cefepime. So you have to be, they are selected and they are picky. So this is another representation that what is important for each organism in this bacteria that you should know them. And we discussed most of the talk in this slide. Here, actually, you shouldn't follow this one. You are not obligated to follow this diagram. This is actually, I call it my cabinet for antibiotic. When I'm facing any case, I am imagining the antibiotic will be like that. But it is not 100%, but this may help you to organize yourself when you are going to select your antibiotics. So in the left side, we have gram-positive. In the red box, which is started with vancomycin and teicoplanin, they are pure gram-positive coverage. And the left side, we have colistin. They are the extreme, we call them, which is pure gram-negative. And in the middle, usually they are broad-spectrum antibiotics coming from the beta-lactam. So these the beta-lactam. And you can see clearly they are divided to 4. Penicillins in the top, cephalosporin, and monobactam, the azithromycin. And carbapenem in the last. And behind them coming the quinolones, which is also the broad spectrum, especially if you go further with their generations, like moxi and levofloxacin. They are almost or more broad spectrum than beta-lactam. And down tigecycline, and we will come to discuss them one by one. In the lower side here, we have more anaerobic, and upper we have more pure gram-positive and gram-negative. And in the middle, it will come, you can combine a lot of coverage. So based on the previous slides that we said MRSA important to know which covering, antibiotic, and Pseudomonas what's important, anaerobe, and atypical. So when you face a case that you want to give antibiotic, you have to ask yourself this question. Number one, what's the diagnosis that's expected in this case? For example, let's say meningitis. So what's the common organism in meningitis? Streptococcus pneumoniae. So you will try to cover Streptococcus pneumoniae. On the other hand, let's say febrile neutropenia. What's the common organism in febrile neutropenia? You want to cover gram-negative, especially Pseudomonas. So you shouldn't leave your patient without Pseudomonas coverage. And here the Pseudomonas coverage in front of you, in front of every antibiotics. So as example, Tazobactam will cover Pseudomonas. Ceftazidime, Pseudomonas, cefepime, Pseudomonas, azithromycin, Pseudomonas. So we have the Pseudomonal coverage, and for MRSA, all these covered by MRSA, and you can see clindamycin as some of the, not maybe few of you think it is only for anaerobe, but no, it's covering MRSA, nitrofurantoin covering MRSA, doxy. So you know that MRSA, they have oral coverage, which is good if the case is mild in the exam. And also Pseudomonas here you can find Cipro and LIFO. سوري يا شباب اللي عنده question يرفع يده ولا يكلم. Cipro and LIFO, they are covering Pseudomonas, but Moxi doesn't cover. So this slide may help you to know which one covering Pseudomonas and MRSA, especially those are two organisms. For beta-lactam, usually they are the backbone of most cases. So if you have any sepsis, you shouldn't leave your patient without beta-lactam unless you have special diagnosis like Brucella. Brucella, there is no place for beta-lactam, especially on some cases like CNS Brucella. And Q fever also, there is a special antibiotic for Q fever. Atypical pneumonia, you know, this is atypical pneumonia and you have to cover with atypical coverage. So whenever there is a septic shock, generalized infection, beta-lactam, they should be always the backbone for your management. And you can add either quinolone or aminoglycoside or MRSA coverage like vancomycin linezolid. Why they are the best for management? Number one, they are bactericidal. Number two, side effect is manageable and it's less side effect than other. And their ability to kill and also their pharmacokinetic to penetrate a lot of area in the body is great. And also their the experience and the studies more with this antibiotic. The problem only with resistant, which is we can see nowadays, it's carry a lot of resistance because of too much abuse for this antibiotic. Unfortunately, they have no coverage for Enterococcus and Listeria, especially the cephalosporin. They don't cover anaerobe also. I'm talking about cephalosporin. Like ceftriaxone, when you give ceftriaxone, you don't think that or cefepime you are covering everything. No, Enterococcus and Listeria, it's not covered. Unless there is a specific cases like infective endocarditis, there is only one recommendation for cephalosporin to cover Enterococcus, which is ceftriaxone. For azithromycin, it's also a place for MCQ, which is the only one out of these can be given an anaphylactic shock for beta-lactam allergy. Unfortunately, it has limited coverage, which is only for gram-negative, especially for Pseudomonas. Quinolone. The area you should know about quinolone, we are usually dealing with Cipro, LIFO, and Moxi. So Cipro and LIFO, they are pseudomonal coverage. Moxi doesn't cover, but Moxi can cover anaerobe. The other problem with Moxi doesn't go with urine, so it's not good choice for UTI. The other issue for MCQ for these, we call them LIFO and moxifloxacin. We call them respiratory fluoroquinolone for one reason, because they cover Streptococcus pneumonia. It's not because they have good penetration for the lung or they are covering atypical. No, because they can cover Streptococcus pneumonia. That's why they called Streptococcus. They called respiratory quinolone. And already mentioned this. The major side effect is QT prolongation. And in case for MCQ, maybe they will bring for tendon rupture. Also, sometimes they are mentioning one of the side effects, which is rare, is aneurysm or dissection. Aminoglycoside, their usage was limited. Otherwise, they are great bactericidal antibiotic, especially for gram-negative. So if you want to summarize them, they are three: streptomycin, gentamicin, amikacin. Amikacin also, it's a brother of tobramycin, so they are same almost. Usually streptomycin uses for Brucella, for Enterococcus, and as you know, another topic different from regular bacteria, which for tuberculosis. Gentamicin, it has good coverage for gram-negative, but also at the same time has gram-positive. And the use for gram-positive as MCQ for gentamicin usually is coming with infective endocarditis, as synergistic medication with other antibiotics. Amikacin, usually one of the best for gram-negative. So with tobramycin used for, especially for pseudomonal infection. Only the problem that they have renal and ototoxicity problem, and they are not great for CNS infection unless the brain barrier was inflamed. Again, all of them, they have anti-TB activities. This you should keep it in your mind with the quinolone. For pure gram-positive, we have vancomycin, which is the famous one. Usually we use it for MRSA. Teicoplanin, it's the brother of vancomycin, but less side effects, especially for nephrotoxicity and thrombocytopenia. Linezolid, it's a great. The problem for MRSA, it's bacteriostatic. But for Enterococcus, it's bactericidal. The place for MCQ in this one, usually side effects, especially thrombocytopenia and serotonin syndrome, especially if you combine it with MAO inhibitor. Daptomycin, usually, and most of you are think it is more strong than vancomycin. Yes, but not always. You should have sensitivity with you. Sometimes it will be resistant for dapto and sensitive for vancomycin. And major use of daptomycin for infective endocarditis, especially right side infective endocarditis. The place for MCQ in here is that doesn't cover pneumonia. And the second thing is creatinine kinase, it will be elevated sometimes, so you have to follow. So in case of rhabdomyolysis and the case and the scenario was given daptomycin, then you should keep it as alert for you. For additional information, daptomycin can be used for lung infection if the lung infection caused by embolism from the right side infective endocarditis, but not for pneumonia. For in the blue, pure gram-negative, we have the colistin, which is the famous. Colistin doesn't cover all gram-negative. Yes, it's strong for MDR, for Acinetobacter, for Pseudomonas, for Klebsiella, for E. coli, but also has no coverage for Serratia, Proteus, Providentia, Morganella, and Burkhardia. It's almost same aminoglycoside for nephrotoxicity. Tigecycline, it's a fancy antibiotic. Is combining all the antibiotics that we discussed as a coverage, but it has two problems. Doesn't cover Pseudomonas, and we cannot call it another problem, but maybe it's bad for sepsis. It has high volume distribution, that when you give it, it will go to the tissue, doesn't stay in the blood. So if you have septicemia, it's not a good option to give it, especially if you'll give it alone, but it is good for soft tissue like intra-abdominal infection. So you cannot give it in septic shock alone, and it doesn't cover Pseudomonas, but cover everything, MRSA, VRE, even atypical and anaerobe. Macrolides, they have, we can say it's a limited uses usually, and you should know them. They are used for pneumonia to cover atypical and streptococcus. That's number one. And also they are a place for question in STD, especially for chlamydia. And also like cat's crush disease and truffle diarrhea, especially in Southeast Asia. So these are the main places for MCQ for macrolides. Again, it's like quinolone. They have problem with prolongation of QT, so this could be a place also for MCQ. Clindamycin, it's a brother for azithromycin, but it has more and better coverage for MRSA and anaerobe. Also, there is a place for clindamycin as a question which has come in necrotizing fasciitis, because clindamycin has antitoxin effect other than its work as antibiotic for the toxin produced by Streptococcus. We will come in the next other slide for this one. Flagell, mainly anaerobic, doesn't cover other than anaerobic, but also has extension to cover some parasites. Disulfide reaction is a place for MCQ, which is usually there is a reaction coming for the people who is alcoholic and using Flagell at the same time. And then we will come to UTI agent. Usually we have two, nitrofurantoin. The trick here, nitrofurantoin use only for cystitis. Don't use it for complicated UTI. And fosfomycin, we have only in case here. I think this is not a place for MCQ, but if came, it's a strong antibiotic and have broad coverage and can cover Pseudomonas and MRSA at the same time. Bacterium, it's same clindamycin, same as azithromycin. It comes with the scenario. So bacterium, you can see it in HIV in case of pneumocystic carinii, and it can come with truffle diarrhea, also you can give it, and even can come sometime with nocardia, stenotrophomonas. So it has limited area for questions, bacterium. If there is a question common, it will be sulfur allergy. So you should be aware which antibiotic has sulfur. Usually it comes with sulfonamide, like Fansidar, which come also in malaria. Doxycycline. If you have a question on doxycycline and you don't know what's the answer, you usually choose doxycycline, especially if it's the first time for you to see the question. More doxycycline will be like, it's the brother of bacterium and clindamycin and MRSA oral. And what we noticed during our interaction for the last few years that everybody doesn't know doxycycline used for Brucella. So if they will use doxy as MCQ, it will be in Brucella. MSSA, here it's like a collection for you if you don't know. When we say MRSA, don't forget MSSA. MSSA, that means Staphylococcus which is sensitive for everything. The problem with MSSA, it's more dangerous. So, because it's a wild, it's carry all the original virulence. So MSSA, easy to be killed, but it's easy to kill the patient also. So this is the covering for MSSA. So if you have patient suspected MSSA or streptococcus and patient in ceftazidime, your patient is not covered well. So you should be one of these. Cefepime, cefazolin, nafcillin, even carbapenem. And when it become a more resistant, like community MRSA, here you can choose the antibiotic. Bacterium, Clinda, doxycycline, they are used for oral. Plus linezolid, also for oral. But linezolid, we cannot use it for a long time because thrombocytopenia side effect. and also neuropathy sometimes. Those in the red, they are for IV. This doesn't cover MRSA. Even if they will tell you they are sensitive, we are not using them for MRSA because they will develop resistance after a few days. So these for MRSA, you should know them. And here for Pseudomonas, again, don't be tricked. This doesn't cover Pseudomonas. And this oral medication for Pseudomonas, other they are IV. And Enterococcus, I don't know about the exam, it's not usual, but if they go for further, this is the coverage for Enterococcus, which is strange. You see penicillin is covering, but cefepime doesn't cover. So it's strange for Enterococcus. When you see it, keep in your mind this the coverage. Don't use cefazolin or ceftriaxone or cefepime, rather than to use penicillin, which is more narrow coverage for it. Duration for antibiotic, use this one always. What you are treating, if in the skin, something simple, usually is maximum 14 days, but the usual 7 days, pneumonia, 7 days. If it is in the bone or enclosed abscess, it will go longer. Infective endocarditis local. Also organism, they are not always the same. E. coli, it's not like Staphylococcus aureus in the blood, not like Brucella. And also you should look for the response. And the most important is controlling the source of infection. If you cannot control and not controlled, then your antibiotics will be useless after a few weeks. They will get resistant. And the last one, your antibiotic alone is not enough. You need immunity. So the antibiotics, they are like a bridge until the immunity can overcome the infection. So if you have immunocompromised, especially in neutropenia, sometimes you cannot stop antibiotic unless your patient becoming immunocompetent, which is no more neutropenic. Any question? Shall we proceed?
Let's proceed.
So in the coming slides, prepared by our colleagues, they are nice slides. They are nice slides. They can make it your review for infectious diseases, especially bacterial, more organized and simplified. So pneumonia, the infection in the chest, in the lung, and pneumonia, you have to cover the most important organism, what? As we said, Streptococcus pneumonia. Second, atypical pneumonia, which there are three: Legionella, Chlamydia, and Mycoplasma. And you know, these three, the atypical, they are covered only with three categories of antibiotic: Macrolides, quinolone, and tetracycline, which is doxycycline. So your management will be based on this information. You have to cover Streptococcus pneumonia, and you have to cover atypical. And you have the information that doxycycline, azithromycin, quinolone, they can cover both Streptococcus and atypical pneumonia. So you can give single agent out of these if the infection is mild. But in case of severe infection, you can combine to overcome, like in patient who is non-ICU, you can ceftriaxone plus azithromycin. And if patient in ICU, still ceftriaxone, especially this, we are talking about community-acquired pneumonia, not hospital-acquired pneumonia. So still ceftriaxone or tazocine plus azithromycin can work. Quinolone alone, if you use respiratory like moxi or levofloxacin. If simple pneumonia, amoxicillin is enough. So if came to your, and the choice is amoxicillin, it's simple pneumonia, choose it. Yes, this is not the practice we are using, but in MCQ, this is the choice. And if they gave you amoxicillin, azithromycin, and the scenario telling you this is atypical pneumonia, of course you will choose azithromycin. If it is Streptococcus pneumonia, then you have to look for a contraindication for azithromycin. Sure, you will find it in this question, either QT prolongation or maybe allergy for amoxicillin, then he will force you to choose azithromycin. For skin soft tissue, make it habit when you have a skin or fascia or muscle infection, 3 things you should evaluate. Number 1, Staphylococcus aureus infection. Now you know it's simple to manage, either MRSA or MSSA. MRSA or MSSA, you can give vancomycin and your patient will be okay, and you can drain if there is abscess. The problem is coming usually when it's coming in the exam, Streptococcus, not pneumonia, Streptococcus pyogenes. The problem with Streptococcus pyogenes, it's to produce a toxin that accelerate the process of immune storm and will cause for you a septic shock, and it will kill the patient soon. So this is the area where the MCQ come usually, and there is a skin infection. You should be aware about Streptococcus pyogenes, which is cause necrotizing fasciitis, and the management number 1 is not antibiotic as a priority rather than debridement and control the source. Of course, plus giving antibiotic. The most important to give antibiotic is to add clindamycin plus minus immunoglobulin to stop these toxins and to help the patient to be stable. Number 3 of an organism, which is gas forming, and usually this we are not facing a lot of MCQ in the medicine in this case, rather than in surgery, which is Clostridium perfringens, which is usually the scenario will come after penetrating injury with gas forming. And it's one of the anaerobic organisms, so you have to add coverage for anaerobic. In general, if you don't have a clue what's the case, you have to cover both MRSA, anaerobe, and Streptococcus. So the best agent for anaerobe and Streptococcus, you can either use tazocine or you combine ceftriaxone with flagyl, and for MRSA, vancomycin or linezolid. Plus all of this with clindamycin, because clindamycin has non-antibiotic effect, which is antitoxin inhibition. GI usually salmonella, but it's not a favorite other than C. diff. And C. diff, now they put flagyl or metronidazole out of the equation, and the first choice always is vancomycin. And if they will go further, they may go for fidaxomicin. If you found flagyl added to the vancomycin with severe, you choose it, especially if IV. UTI, usually the question will be with the pregnant ladies. This is the area for questions because it's easy to answer if they will give you a simple regular scenario. And E. coli, Klebsiella. Staphylococcus aureus doesn't come as a common question for UTI, and if came Staphylococcus aureus in UTI, then he's giving you a hint this is a systemic infection rather than UTI, and you should go for bacterial and infective endocarditis. Be cautious with UTI. They like to use and to follow the guideline. So simple UTI, go for simple antibiotic. And for pregnancy also, see what's the common use in pregnancy. Like nitrofurantoin, it's thought it is not used for pregnancy, but it is the best for pregnancy if in case of cystitis only. For arthritis, number one, Staphylococcus aureus. And if you cover Staphylococcus aureus, by default, you are covering Streptococcus species. So if you have no clue and there is no risk for MRSA, use simple, even ceftriaxone or fluoxetine. If MRSA, vancomycin. CNS infection, here is a problem with this slide. It should be edited a little bit, so be careful. So for meningitis, immediately you should keep it as a low. Ceftriaxone, double dose 2 gram BID plus vancomycin. The reason for adding vancomycin is not because of MRSA are less than 5% in community acquired meningitis. The reason for adding vancomycin in meningitis, that's because ceftriaxone doesn't reach fully to the brain. So you are giving double dose, but still your double dose doesn't reach 100% to the brain. So that's why you add vancomycin. Hopefully that two antibiotic, they can reach to the brain or meninges to kill the Streptococcus pneumonia that you think it is the cause of your meningitis in your patient. So the reason to add vanco plus ceftriaxone, because we want to hit and make sure the meninges of our patient has enough antibiotic to kill Streptococcus pneumonia. If you have some area where, some cases where listeria is there, then now you because we discussed that listeria doesn't covered by vancomycin and cephalosporin, then this is the area where we should give 2 beta-lactam together. So we can give ceftriaxone and ampicillin, ceftriaxone for Streptococcus and ampicillin for listeria.
Can you look to the questions in the chat?
Sorry?
2 questions in the chat.
Yeah. Doxycycline 100 milligram BID. Doxycycline, when it's mentioned, OD. I think doxycycline, which here. No, it's BID. Yeah, this one is not corrected. And even 200 milligram as loading dose is not what we are doing always. We are giving 100 BID. Nitrofurantoin, yeah, we can give in the third trimester. The problem only with third trimester is with bacterium. Bacterium, you should avoid it in the third trimester, especially the last 2 weeks, and the first trimester.
What is the most common cause of febrile neutropenia, gram positive or negative?
هذا قدامه هاي ما شاء الله مستعجل تو تطلع السلايد حق النيتروبينيا. So gram negative is the most common. The most common for neutropenia gram negative, and you should combine with them Pseudomonas. The reason why gram negative, The logic telling you it's a gram-positive, but it's a gram-negative because most of the people with febrile neutropenia, they have received chemotherapy and their GI tract exposed, and most of the organism in the GI, they are gram-negative. That's why when we have febrile neutropenia patient who became febrile after neutropenia due to chemotherapy, the gram-negative is number one. Number two will come gram-positive, and there are many clues that to get gram-positive coverage, which is either your fever is not subside after covering gram-negative, or if he has access for gram-positive, like skin infection, mucositis, and central line or portacath. So here for immunocompromised neutropenic patient, you can give one of these. The only issue here, ceftazidime, we don't prefer it in neutropenia patient because ceftazidime, it's one of the cephalosporin which is not good also for gram-positive. What we mean by gram-positive, that means Streptococcus pneumonia. MRSA is different, Staphylococcus is different. So here the pregnancy safe antibiotics. So one of the question was nitrofurantoin. As we said, it's the same for bacterium, especially near term. You can give it in the third trimester, but not before delivery, especially the 1 week before delivery. And to avoid, I think well known, especially tetracycline, avoid. Quinolone we can use, but in the exam, avoid it in the MCQ. There's a collection for common side effects which come as MCQ. For side effects, usually they are concentrating on the catastrophic side effect. One of them, ototoxicity, nephrotoxicity, and Stephen Johnson and sulfa allergy. This is the area where they're concentrating on side effects. When to consider MRSA coverage, this can be helpful in case, especially of febrile neutropenia. The most important, use of antibiotic during the last 3 months. And down you can see the IV option and oral option for MRSA. Pseudomonas, it's almost similar for MRSA, but the additional thing with Pseudomonas is come with a condition, even if they don't receive antibiotic, like cystic fibrosis, being in the hospital, because MRSA, if in the hospital and you have information that MRSA less than 20% in biogram, there is no indication, but for Pseudomonas, no, it's direct you should use. Neutropenia, transplant. HIV with low CD4 usually is not a place for question, and it's not a real indication for Pseudomonas, but rather than risk. Same for Pseudomonal, there is a name of antibiotic mentioned down for your reference. Thank you.
Thank you for watching. Thank you, Dr. Mohammed, for this brief